All right, Cheryl, go ahead and take it away.
Okay, thanks, Katie. Welcome, everybody, to our Finance and Revenue Committee. I think it may be, I don't know, the 6th time we're meeting, something like that. I want to first thank Morgan for your support and work as the executive director of the board, and I know this has been a lot. I've appreciated so much your support. I wasn't sure if all of the committee members knew you were leaving, but I thought I would say that. And wish you all the best in your new position. It sounds very exciting. Working for the newly elected Congresswoman Maxine Dexter as her district field office director. So that's great. So congratulations, and I will miss you terribly. Would you like to say anything, Morgan?
Thank you. I said at the board meeting, it's been an honor to serve in this role and to work for the board and all of these committees and get things started. And I'm very confident in the process that the board established last week to hire a new executive director, and very confident in Jenny Donovan playing the interim role to continue to keep things moving. So best of luck, and I'm sure I will see all of you in other places soon, since Oregon is so small.
Yeah, thank you, Morgan.
Congrats.
So with that, we'll move on to the tech check and the roll call introductions, then we'll review the agenda. So I'll pass that over to Katie.
Thank you, Cheryl. And as you all know now, how to function with Zoom in the meeting, so no need for a tech check. Just a reminder to those members of the public that are joining us today, thank you so much for being here. You're not able to connect your camera or your audio. However, you are able to be here and listen. And we do very much encourage public comment. So if you would like to be able to participate with the committee in more capacity, please check out the UHPGB website on how to provide public comment, because I know the committee loves to hear from you. But with that, we will go to roll call, and we will start with Bethany Stairs.
Present. Sorry, I couldn't find the mute button.
Thank you, Bethany. Charlie Swanson.
Present.
Cheryl Ramirez.
Present.
Chris Hogan.
Here.
Chenwei Chi. Are you able, did you say something, Chenwei? I didn't hear you, in case you did. Or maybe he's frozen.
Hear me?
Oh, there we go. Okay. Thank you, Chenwei.
Can you hear me?
Yes, now we can. Richard Gibson.
Here.
John Santa.
Here.
Jeff Goodman.
Here.
Thank you very much. And then Sam DuPont, we also have on the committee, but she's not able to join this month. So with that, I will turn it over to Cheryl.
Katie, I just want to note that several of us have C names. I didn't notice that before. Okay, so I'm going to review the agenda. We have quite a lot to talk about today. We're going to start talking about revenue parameters, administrative savings assumptions, and we'll review ERISA. You may have seen that there was a recording of the presentation by ERISA experts Erin Fusay-Brown and Liz McCuskey that they presented at the November board meeting, and that was sent out with your committee meeting materials last Friday in case you had a chance to watch that recording. Jenny's going to be sharing a high-level overview of that presentation, and the goal for our committee today is to figure out if we have any additional questions that need to be answered about ERISA. Then we'll get an update from Charlie on the health expenditures estimates. It looks like we'll be diving into long-term services and supports today. Charlie sent some presentation materials and an updated spreadsheet. You should have received that on Friday. And just a heads up, the board has asked us for a straw proposal regarding the health expenditure work. So I'd like to discuss, as we're in that particular agenda item, what that's going to look like, how we're going to do that. So just be thinking about that as Charlie presents his work. As usual with any of these presentations, they'll be interactive. So comments and questions on a particular slide are allowable. Just use the hand raise button. And then last, we'll share reflections from today's meeting and talk about the agenda topics for the supplemental committee meeting that we have scheduled on February 4th. And then we had one written public comment. I hope you were able to read. And as far as I know, we have one person providing public comment during the meeting today. So with that, we'll go through the feedback from last meeting. If we're missing anything, please let me know. So last time we reviewed and agreed on the changes of the guiding document with edits. I believe Charlie sent an edited, one of the principles was edited. He sent that by email. So I'm assuming then we're good with the edited version. And I believe Morgan or Katie, correct me if I'm wrong, that you'll be sending the final version with the edited version to us and also to the board. The board did ask to see the guiding documents. Is that correct?
Yes, that is correct.
Okay, thanks, Katie. We agreed to request additional information from OHA about the agency budget, and then there was a question for DHS on voc rehab. I thought I saw an email from Charlie crafting that particular question for OHA. Do you want to mention anything about that, Morgan, about that request, or will we be talking about that later on? I don't remember.
We could talk about it when we talk about health expenditures.
Okay, all right. Let's see. So I mentioned to the board that we were talking about using 2030 instead of 2028. They seemed a little surprised by using that 2030 for the revenue estimates. I suppose that could be part of our, no, wait, I was going to say that could be part of our straw proposal, but that's on the health expenditures, not the revenue. So we could keep thinking about that. We agreed that an executive summary will be essential for this work. This is so complicated, so in the weeds that for anybody just trying to figure out, what the end plan is, I think we'll need to really boil it down to the essentials, and everybody did agree that was something we'll need to work on. We haven't resolved the issue of whether there'll be a kicker for the tax. I think sounds like we need to get some legal opinion or legal assistance, and I don't know if we settled on who that might be. And then lastly, John brought up last time that we need to understand Medicare funding better and what that will mean for revenue options. And so that will certainly be another topic at one of our committee meetings. Anything else that we didn't include in the summary feedback from last time? Okay, so we'll move on to the revenue parameters. Is Kyle here?
Yes, he is.
Okay. So I want to welcome Kyle back to the meeting, especially the first day of session. I know how stressful that is. And we'll just invite you to talk about the revenue parameters. And if you'd like, Kyle, you can, if someone raises their hand, you can call on them. I'll leave that up to you. Otherwise, I'll help you monitor hands raised. So with that, I'll turn it over to Kyle.
Okay, yeah, that sounds good. Thanks, Cheryl. And I'll keep an eye out for hand raise. And please do raise any questions at any time on whatever slides. Because I think that's again, more of a conversational tone is helpful. But I am Kyle Easton with the Legislative Revenue Office. It's nice to see you all again. I think it's been a month or so since I've been with you all, and that's really the goal, or what I have for you today is really a follow-up of the previous presentation with some of the questions that came up. So to try to dive into a little bit more detail in those areas based upon the previous discussion. So we can go ahead and advance one slide. Yeah. So in terms of the high level topics, the statewide property tax was one area. Another was sales tax and addressing regressivity. And then the final one I have here is kind of the personal income tax, payroll tax, how those two overlap a little bit, and then talking about the tax base and some of the differences in not too much detail in distribution, but just a little bit of a discussion on the different types of income that income taxpayers can have, whether it's wages or different sources, business income, those type of things. But so that's kind of the goal of today to step through. So I'll start off with the property tax. In terms of the property tax, this first slide, this is the property tax base. And I think that's always helpful to start with the base because the revenue dollars you all are talking about are sizable. So you're going to need a sizable tax base to raise any revenue of significance, really. And so the property tax base here, what you have is this is going back to 95, 96. And the blue line there is the real market value. And then the dotted orange line is assessed value. And this is based upon Oregon's current property tax system. So Oregon does have a distinction between real market value and assessed value. I'll get into that in a little more detail later on in just a couple slides, as there is a policy call on how you all would want to shape something if you did to utilize the property tax, a statewide property tax, if you will, for universal health funding. But this gives you a sense of just the size of the tax base. It is quite sizable, and it has been growing relatively steadily. You can see the blue line, real market value. There are some ups and downs. You can see kind of the housing run up in 07, 08 as that was really growing. And then you saw the Great Recession where we actually saw real market values decline. But overall, it is definitely a tax base that trends upward and does have decent amount of stability, although you can see these large trends that can occur. So things maybe don't dip the same way that a personal income tax can go up and down year to year. The property tax might be more steady, but you can have 3, 4, we have experienced 5, 6 years of outright declines in the past. And you saw that following the Great Recession there in 07, 08, 09 period. We can go ahead and advance one slide here. So in terms of the property tax, a statewide property tax, we did touch on briefly at the last discussion, working within the parameters of the existing property tax system raises some challenges because of, I won't go into too much detail on it on the Measure 5 and Measure 50 limits, but the long and short of it is if a statewide property tax was simply put in place right now, you could be putting downward pressure on existing tax revenues through the property tax system due to our Measure 5 compression limits. And that was a concern. I think that was raised by you all. And so one way to mitigate those would be through a constitutional change to institute a statewide property tax that would essentially work outside of the existing property tax base. And so in doing that, and I don't know how familiar people are with what get referred to as the Measure 5 and Measure 50 limitations on the existing property tax, but doing a constitutional change, I think you can think of it as okay, sorry, something just muted, oddly enough. Okay, so a constitutional change would simply wipe the slate clean, and you can start over for the new healthcare property tax. It would give you the policy flexibility to put something in place that could work from the existing property tax system, the property tax base, but wouldn't necessarily interact with existing tax bases of, say, county governments, city governments, and such. So it gives some flexibility in how you'd want to design something, but that would be through a constitutional change. And so some of the questions that come up then become, do you want a system be based on a statewide tax rate, or another approach is a levy-based system? And key difference really between a levy-based and a rate-based is a rate-based, you can establish a taxing rate, you apply that rate against property values, and that leads to your revenue. And of course, you could put in place a maximum rate and you can always impose less than that. But again, the rate and the property value determines your revenue, where a levy-based system works almost in the inverse, where you decide what is the revenue that is needed. And then the formula here at the bottom of the slide, you have the revenue need divided by the property value gets you to that tax rate that then gets imposed. So it's kind of a different way to look at it, where you say we need X amount of dollars, and you impose a levy to that, and then you back into the rate that then gets applied to the individual properties. And Richard, I see.
Yeah, Kyle, so is Measure 50 basically saying that the assessed value can't go up more than 3% per year? And that property tax based on that 3% increase is limited in that same way. So if you put in a new property tax that's statewide, everybody else is going to have to decrease theirs, or else you're going to go over the limit. Is that generally what's going on here?
Yeah, so Measures 5 and Measure 50 work somewhat together, and Measure 5 limits are those hard caps that you're talking about, where you can't impose X amount of dollars above the constitutional limits. And then the Measure 50 is really that growth limit, that 3% growth limit. So taken together, it limits the growth, and then Measure 5 limits the total amount you could impose. And that's where Measure 50 would limit it, I guess, the growth in any healthcare task force revenue. And it also imposes this distinction between real market value and assessed value. That's how that limitation on growth is put in place. And then the Measure 5 limits are those overall limits that can, for lack of a better word, cannibalize other sources of revenue. So a new statewide property tax comes in, and it would hit local option levies especially hard on the general government side. So they could decrease revenue for, say, a city taxing district by putting this new property tax in place. So those are the challenges of the existing system. Yeah.
Thank you.
And Jeff, yeah.
Another challenge is going on right now in downtown Portland. The commercial properties where the real market value has gone to either at or below the tax assessed value, and then the rate is then applied to the lower of the two. So in contrast to the graph that we had in the previous slide, this is the case that's really hurting Portland, because the tax assessed value for the first time, I think ever, has gone below the market value for commercial office properties in downtown Portland.
Yeah, that's an excellent point, where you really do have, there is a little bit of growth difference. And that overall, that first slide I showed, that was statewide. So that definitely glosses over some of the differences in growth in different areas. And especially in that, like, just post the Great Recession period, the 08, 09, 10, 11. I know examples that came up in the legislature were certainly in the Bend area. You saw big swings, which they've had a lot of growth as of late back, but they had big swings in value as well. So there can be differences especially in like specific areas that would look different than that overall chart that's just a statewide. Yeah. Charlie.
So my understanding is that Measure 50 also has another limitation. There's a freeze on, I think, at 1995 values within each district that I think limits what can happen in various taxing districts lower than what the Measure 5 limits are. Is that correct?
Yeah, so that's a very good point. In terms of Measure 50, Measure 5, what Measure 5 did is it was actually fairly simple in that it just put overall caps on its dollars per real market value. So it's basically a cap on what property taxes could be, but they were still based on real market value. Measure 50 came in and limited that growth in real market value, and also converted what was basically a levy-based property tax system into a rate-based system. So taxing districts were given rates rather than levy amounts. So those rate amounts became fixed. And so districts can impose less than their maximum rate amount, but they can't impose more. Where the levy system used to allow more flexibility, there was still an overall limit of like 6% year over year on that levy increase. But it did Yes, the changes together really did overall caps on property tax and then limit on growth and convert to a rate-based system. So those are the big changes in the existing property tax system. And that's where a constitutional change not only can seek to avoid interaction with the existing property tax system in terms of negatively affecting existing property taxing districts, but it does give you all the flexibility. Do you want those growth limits? Do you want it to be based on RMV? There's a lot more options that become available, which could be good or bad. It also adds complexity and more decisions that have to be made by your group, for sure. But that rate based and levy based is also a big one as well. That can help in terms of what the revenue need would be in providing more. If you're thinking from the revenue need perspective, a levy based is great because you get the revenue you need. From a taxpayer perspective, it works the other way where your value may not change, but if the levy goes up, you're paying more in taxes. So it can kind of work counter, of course, to the tax paying properties. But those are two key differentials in terms of a policy perspective. Okay, let's go ahead and advance one slide here. In terms of defining the tax base, again, the working from a real market value in property is different than existing law, which we're working from an assessed value under our existing property tax system, which I don't want to say is it doesn't matter what your real market value is. There's a lot of interactive, and I'm being very high level and not going into too much detail here, but it does give some real market values move more, right? They go up, they go down to the point earlier was like the commercial property has definitely changed quite a bit in the Portland area. So real market values will move around a little bit more, and that can change the revenue that's coming in, and it also will affect individual taxpayers differently too, as their property values are going up or down. I mean, that is the benefit, if you will, of our existing property tax system is there is a limitation on growth. So from a taxpayer perspective, that's helpful to them because their taxes don't go up and down as their market values are going up and down. But that's a key question there. I think I've hit on the levy based and the rate based. Again, a policy question on how to approach it. And then the last bullet I have here was property tax relief. And that's something that in many ways has gone away from our existing property tax system. We still have a senior deferral program and such, but because of the limitations by measures 5 and 50, we have seen some of that former relief programs have expired. They've gone away. Instituting a new property tax, imposing it on real market value, that could raise the need for some of this property tax relief. Again, whether that's focusing on, I mean, what often comes up is lower income households. The property tax can be regressive to especially lower income households. Example that comes up is often property owning seniors that are on lower incomes. They can be have the property tax imposed on them, and they don't have a whole lot of income coming in. So ones that come up are, would you want to include some relief for those low income households, age-based, deferral programs, just trying to list it to put that all in your all minds moving forward, as if you switch to a real market value system, especially, there could be some need for adjusting those parameters that aren't in our current system today. And then one other note on, I guess, in defining the tax base, existing property tax exemptions, the upside of using a property tax system is we have one. So there are tax assessors, they're already putting values on property. So you can definitely piggyback on some of that, even if it's done differently. But there are existing property tax exemptions for, say, businesses that if they invest X amount of dollars into this new property, it is exempt or it's partially taxable or something along those lines. So that may be something that, whether or not you want to bring those exemptions into a new property tax base for your all needs, that's something to be thinking about as well. And with that, I just have an example there of especially the difference between real market value and assessed value that we see. This is statewide values, but there is quite a difference between our assessed value and real market value due to the growth over the past 20 years and what that tax liability would be. But that's the last I had on the property tax, so I can pause there if there's any further questions on that, or we can move right into sales tax. John, did you have one on property tax?
Yeah, I did. It's complicated, but let me try to explain it. My focus is on where currently are revenues coming that pay for, if you will, premiums or healthcare costs. And my sense is that currently the premiums and administrative costs for healthcare for public employees not working for the state, but working for school districts, recreational districts, etc. A portion, if not all of the dollars funding their healthcare is in property tax. So my question is, could that amount be calculated and essentially be raised in the environment we hope to create and go directly to the single payer rather than, through a public employer? Okay, so this would be a specific, when I get my property tax, I always look at how much going to police, how much fire, how much, the schools, etc. And so there would be a line on there that would say, public employee healthcare premiums. Is that possible?
That's a very good question. And so thinking about this one, I know it came up in the work group previously where this was a discussion topic of essentially you're taking away an expenditure for a local government, removing that expenditure for property and not property, for their insurance payments for their employees.
Yeah.
And right now, that's part of the revenue that they're raising through their revenue streams, which is going to be primarily, to your point, property tax for local government. So you're decreasing a cost and they still have that revenue authority. And so the question is, can you capture that? Is that?
Yes.
Okay. From the conversation I remember that were had last time, I think that becomes a different question of, can you convince a city government, one, to give up that revenue source? Because they would have the authority in terms of the property tax system with their permanent rate to continue to raise those dollars. That might be more of a policy question on how to try to capture some of that revenue. But I think that would be a challenge to you basically be saying, making an estimate and then trying some way to get them to hand those dollars over or to impose a different tax. I think that's more of a policy framework than it's like, can you do it? I guess that's a pretty detailed question. I think that's probably more conversations to be had. And I think the local taxing districts would probably have some say in whether or not they want to give those revenue streams up or those dollars up.
Right. Really, my question is more, could you do it? I realize no matter what you choose to do, you would have an interesting policy and revenue question going on between the state and all the local public employers. I suppose another mechanism would be for the state to say, well, we're now going to be taking on the quote state through the single payer is going to be taking on responsibility for the healthcare for your employees. And so every year we'll deduct the cost of those quote premiums from other funds that we're paying you. The schools all get substantial state funds, I think. I mean, every year there's a big budget item in the state budget for schools. So you could do something like that. But in some respects, I thought as I looked at your slides and thought about this, and my own feeling is not to use property tax just because of the complexity of it. But when I thought, well, there is a piece for healthcare in there that is significant, and would it be best to just be transparent about it and just seek to specifically address it within property tax, so the taxpayers also can be certain that they're not being double taxed. You follow me? That you'd be getting tax to pay for public employees over by the single payer / state, and their property taxes aren't being decreased in proportion to that. Follow me?
Yeah, and I think in viewing this, and I make a point this on, I think, a sales tax slide, but it's probably worth thinking about any revenue package you had altogether, viewing that in totality Because I could see if you're instituting a payroll tax that's levied on the employer, then the local government employers might be substituting existing health insurance premiums, and now they're making a payroll tax. And in that
That's fine.
case, you're
Yeah.
not changing, they would still need that revenue stream from the property tax. So it's probably, if there's a system that's decided on these revenue sources, thinking holistically, how is that system affecting employers and individuals, rather than looking at the individual revenue streams? Because yeah, it's all a very good point on how this interaction would occur.
Yeah.
Yeah. And I don't know if it was Charlie or Cheryl who had
I'll
their hand.
defer to Charlie first, because I just wanted to check the pulse of the committee really quick before you move on.
Okay, so I really like John's idea, but I also think that it's very likely that we will have an employer payroll tax. And I think we'll learn more about this in the ERISA talk, I think, but I think we might not want to distinguish between the rates of the payroll tax for public employees and private employees. But I think there was still going to be some extra funds that we could maybe get at in the way that John is describing, because in general, public employers pay a substantially greater portion of their total payroll and benefits towards health insurance than do private employers. So I like the notion, at least thinking about this notion of using a bit of the property tax, if to the extent we can identify it, as going towards the state system. But I think that, as Kyle said, I think we have to balance that with the potential employer payroll tax. And it's probably going to be somewhat difficult to do that, but I think it's worth thinking about. So.
Cheryl, did you want to jump in?
Yeah, I just wanted to check the committee's pulse on a couple of things. One is on the levy. I don't know if I've missed it in the past, but I didn't think of this as an option. I've been in other states in which levies were raised locally for behavioral health services and IDD services, intellectual developmental disability services. And I thought, wow, that's something I hadn't really considered for this revenue. But I'm curious as to whether any of the other committee members see this as a viable option, or if you have strong feelings about it one way or the other as an option or not. So that's one question. And the second is whether you agree that we should look at the real market value in considering property tax, or if you have strong feelings against that as well. So those are my two questions. Just wanted to see where you're at, and maybe you don't know yet, but wanted to ask. Anybody have strong feelings about either of those two things? Charlie?
I mean, to me, some of what you were asking about, I think, would require constitutional change. And so I think it's going to be really important at some point to try to get substantial public input on potential constitutional changes, that especially related to revenue. So, there's one going to be related to the property tax. And I think before we get too far along in thinking, yeah, we could or couldn't do it, I think we need to get a lot of public input on, would the public go along with this? A constitutional change. And I like the notion of potentially allowing areas to say, we'd like to put a little bit more into behavioral and mental health, and to allow that to happen. So I think that's a good notion, but some of that's going to require constitutional change. And again, the other constitutional change that we may have to think about, we haven't gotten a legal opinion on yet, is related to the kicker. So I think we need to get serious public input on some of those things.
Okay, thanks, Charlie. Anybody else have some reactions to either of those, the levy or the real market value consideration?
Well, in terms of property tax, it looks like it's a non-starter just because it would require a constitutional change. And I think just trying to reimagine healthcare in Oregon is big enough, and having to do a constitutional amendment to raise taxes, just doesn't seem to be very likely. In terms of real market value versus assessed value, that seems even worse. If you look at how real market value has gone up, I mean, taxes would be great there. I didn't understand, so I don't think either one's likely, in my opinion. But Cheryl, I also didn't understand what you meant by a levy. What you mean, a levy that would be a property tax?
Yeah, that it's assessed locally, like in a county for a particular thing. That's what I understood Kyle to explain to us, that you could assess a levy for a particular program. You know, in this case, it would be universal health care. And I've seen this work in other states for particular services. And I gave the example of behavioral health or intellectual developmental disabilities services.
But wouldn't that be subject to the same Measure 5 and Measure 50 limitations?
I don't know enough about it. This is the first I've even noticed that levy was on the list. So that's a good question for Kyle.
Yeah, it working with the existing system, yes. And the levy based is really, the idea is you start with the revenue need and then you back into a tax rate. And before measures 5 and 50, Oregon's tax system was levy based. And then they had limitations on what districts could raise year after year. And that's where it's like, I know there were some exceptions, but it was roughly 6% was sort of the limit. So your levy couldn't be more than 6% of your previous years. And so that could be a process you could use as well for healthcare. The benefit of that, again, you can adjust a rate as well. You can always do less than a rate, or you can have parameters for your rate. But a levy-based system, if you need, I'm just going to say $1 billion, and the next year you need $1 billion plus 50 million or something like that. Even if RMV is going up at a very quick rate, you're backing into that rate amount. So it's the levy that drives the amount. So your rate could actually go down year over year because it's levy based if RMV is growing faster. Whereas a rate based system, if you just let it run on autopilot, if RMVs are growing at 10%, your revenue is growing at 10% plus any new property. But again, you can adjust that rate to make sure it's not growing faster than the revenue you need. But it does it's a little bit of flexibility in terms of that levy based system. I don't know if I want to say a downside, but from a taxpayer perspective, if you have timings where there's RMV declines, real market value is declining, and you're a levy-based system, you could see taxes going up as the value of your home's going down. And so that can just be a challenging thing, I think, for people to see when they open their property tax bill as the property owners. And that's maybe a downside of a levy-based system, is it can just keep going up and up and up regardless of what value is doing.
So what I'm hearing is these two options aren't realistic, probably.
Yeah, again, these are all just trying to lay it out there, and I'll leave it all to you all to decide what would be the acceptable to, the public. And again, the constitutional change does give you the flexibility to work outside of the existing system. But again, that puts
That's a pretty big
requires a
lift.
constitutional change.
Yeah. Okay. Thanks, Kyle. Please continue then.
Okay, so pivoting to the sales tax. And this was a slide you all saw last time. It's just showing the tax base. I was using the Washington sales tax base and then overlaying it with the Oregon personal income tax, just to give some sense of, the sales tax is a large tax base, and it does grow at a decent clip. But this is the same one you all saw last time, so I'll move through that one pretty quick. In terms of the topic that came up, I think, with sales tax was this sales tax regressivity. And again, regressivity is just, you can think of it as like the tax liability or the tax incidence is falling greater on individuals with lower income, or it's not growing as incomes grow. So it just means it's hitting, I guess, the lowest income harder proportionally than it is the higher income folks. And that's usually how a sales tax works, just based upon how it's structured, because of consumption patterns. People of lower incomes are consuming or buying more things as a percentage of their income than those at the higher income level, due to savings. And then also just sales tax is generally more on retail sales, but it will exclude in a lot of cases purchases of services. But so sales tax regressivity, what are some approaches to sales tax relief? That was the question that came up. In terms of what other states do, because a lot of other states have a sales tax, the two approaches, you can think of them as two categories, I suppose. The first one is just straight sales tax exemptions. And that is basically, you can think of it as groceries would be maybe a good example. Groceries will be exempt from the sales tax. So you can identify certain goods or services that you want exempt from the sales tax, and you can try to do that in a way that is identifying those purchases by maybe where lower income folks are more likely to purchase more of that. So you can try to adjust that regressivity using an exemption, or then you can also, another approach is credits. And I actually have a slide on that, so I'll get into more detail on that in just a second. And then the last bullet here, and I mentioned this earlier, was in terms of a sales tax, it's probably worth thinking of the entire revenue package. If there is one, if there's multiple levers that are being pulled, examining that in total when thinking about progressivity and regressivity. Because again, the sales tax could be a little aggressive, but you could be countering that by a payroll tax and by an income tax and and what have you. So it could be worth looking at the package in general and saying, well, the package overall is actually progressive, even though the sales tax might be pulling back or pulling down on that progressiveness. So it's worth thinking of it that way. Let's go ahead and go forward one slide here. So the sales tax exemptions, again, I gave the example of groceries, prescription drugs, medical equipment. Those are ones that a lot of states do. Within an exemption, you are narrowing the tax base for all. So it is less specific. So if you make groceries exempt from the sales tax, groceries are exempt whether you have income of $1 million or $25,000. So it does make that tax base that much smaller. So that can, over time, or the more things that become exempt, the higher your sales tax rate has to be on the remaining goods to raise the desired amount of revenue. So it's a little bit less specific in terms of that relief, but it's something that a lot of states certainly pursue. Sales tax exemptions, and an upside of that is it provides immediate relief. So when you go to this store, or if you purchase something online, if it's not subject to the sales tax, you don't pay the sales tax right away. So that's the benefit of the exemption, is there is no paying the tax and then getting a refund later. So that's a benefit. And then I did know that in a lot of states, the taxation of services is often limited in the sales tax base. That's changing over time, as I think states are starting to expand into more services. That's more of a historical in nature, but that is often the case, is that it's easier to tax the retail transactions of a good than it is the services. And so that adds to that regressivity. Okay, let's move forward. So in terms of sales tax credit, that's another approach that there are examples of other states on how they do these as well. But an idea there would be you can use maybe the personal income tax system or another tax system to provide a refundable tax credit. I have blanks here to just kind of give an example where it might be a refundable tax credit equal to, you can specify a dollar amount, and then depending on the number of people in the household or on the tax return, they get X amount of that dollar amount times the number of people, and then you can have a threshold that phases out as income goes up, something to that effect. So it can often be one of those where $700 is maybe an example of what an individual pays on sales tax or something like that. So you start off with that, and then you phase that credit out as their income goes up. So the upside there is it can be a little more targeted in the tax relief, where an exemption is broad-based for everybody. A credit can be targeted. The downside, if you will, often comes up with you do have to file a tax return to get this refund. So if you're not subject to the personal income tax, if that's where your tax credit is, then someone has to file an income tax return just to get their hundreds of dollars back for the sales tax. So there can be a challenge there. And then the timing of the relief is always one of those where you would get your sales tax credit when you file your tax return. So that'd be once a year generally, not at the time of the sale. So you wouldn't get that relief right away. Like an exemption would just avoid levying the tax to begin with. And then the last bullet I had here was just managing the tax credit's tax base. So again, the way other states I think do it is they use their personal income tax to provide that tax credit. That could work if you're doing a healthcare task for a healthcare income tax. But if you just do a credit against the existing tax, personal income tax, that would hit the general fund to offset the sales tax for the healthcare. So there could be some interaction or something just to have to work around there. There are definitely ways to do that, but it's just, again, raising that as a policy point on how that would work going forward. Okay, and then the last thing I have here is personal income tax and payroll tax. The first chart you have here, these are income components by income level. I took these next two slides, actually came from a presentation that was given to the larger governing board by Chris Alanek of our office, the head of our office. But really the takeaway here is just to illustrate on the personal income tax side of things, different taxpayers have different sources of income. And so the pie chart on the left there is the middle 20% of personal income tax returns. And you can see wages is dominating their sources of income. It's about 74%. And then there's other sources, retirement being about 15%, but it gives you a sense, wages are the dominant source. And depending on if you had a payroll tax, those may or may not be subject to that tax. And you contrast that with the top 1%, where you see wages go from being about 75% of overall income to about 29%. You start to see interest and dividends, capital gains becoming much more prominent for those. This is the top 1% of income taxpayers, but it gives some sense of, well, maybe that's where personal income tax comes into place to grab some of that or to capture some of that revenue from those sources of income. Because for those top 1%, the payroll tax or the wage tax wouldn't be capturing a lot of their sources of income. Yes, Charlie.
Yeah, so on the retirement portion, especially for that middle 20%, can you break out what is Social Security and what is other retirement income? I mean, because of the Oregon Constitution, Social Security is not taxable, whereas the other part is.
I don't have it in front of me, but yeah, that's a point, and I think these are some older slides. It's something we would probably want to remove moving forward. I think that's a very good point, because it is off limits, if you will, those Social Security tax, because that would be a portion of that. And yeah, so moving forward, I can send something to Morgan as well on what that rough percentage is, because it definitely shifts as you move up the income distribution as well. How much is Social Security versus other sources of retirement?
Great, that would be very helpful. Thanks.
Okay.
But can I just, John, can I clarify, in that retirement 15%, there's no revenue from Social Security taxes?
This one, I believe, John, on this one, that this is just grabbing the total, would be from total income. So it would include the portion of Social Security that is taxed at the federal level. Because I think this is the source of this information is from basically like the 1040, the federal tax return.
Okay.
So we could subtract that off, because that's how it does when you file your Oregon taxes, is you subtract the amount that's Social Security. So it doesn't show up quite the way, but yeah, I will make a note of that and send that out to give a sense of where that distribution is, because that's another point with retirement, which is, not to get too much in the weeds here, but of course, a lot of retirement income is maybe not taxable at the time of retirement, right? You can have different tax deferred, whether you're doing a Roth IRA or like a traditional IRA, and that's kind of key too. So there can be different. I suppose if there was a new income tax in Oregon, that would be another encouragement to try to maybe avoid that by paying the tax today and not paying it in retirement or something to that effect. So that's always a challenge with retirement income as well, is that, and that will not be reflected then on the tax returns. So that tax exempt retirement income wouldn't show up here. But that is a challenge on the retirement side moving forward too.
Right. I mean, I think, especially since what we're doing could involve very significant Medicare, revenue needs, how the over 65 population is treated from a tax point of view will be of interest to everybody, because that could, I should say we, because I'm one of those, we could benefit substantially from what's going on. And it would be only fair to contribute revenue to that. And you know, I was impressed when I looked at this, how small the retirement is for the top 1%. That struck me as interesting.
Yes, yeah, and that's a very good point. And again, the top 1%, these could be of different age groups, and
Right.
certainly can reflect just how much other sources of income come in as well. Because you do have, yeah. But that I think if we want to go one slide, that really sets up the next slide, which is the same information portrayed by age, what's on the tax return. So you have, working from the top left, those are the under 19, the age group, then top right, 20 to 39, then we go 40 to 59, and then the 60 plus. And you can really see how, I mean, wages is the thing that stands out, as wages start off as a very high proportion of income, and then they slowly become less as a person, as their age increases, to the point where you get to retirement where wages are about 26%. These are for the 60 plus. So that's not reflective of people that are retired, but just those that are 60 plus. And it does show how those income, the sources of income really do change over time. And whether, especially with how you all are thinking about this, if you're thinking a payroll tax and an income tax, and maybe those are the idea is to capture different sources of income. Because that was one other point I wanted to make, is a payroll tax and then an income tax, there may be something you want to think about from a policy perspective, is a need to provide, say, an exemption on your income tax side of things for those taxes that are paid on the wages via the payroll tax. And maybe that depends upon whether it's employer paid or employee paid, but you could see very, very quickly where you could be levying two taxes on the same dollar of income. For the same, I mean, we do that today, but those are for distinct different purposes. So you might be levying for, the general fund, and then you have something for unemployment. Those are different programs, where this one would be the same program, if you will. So that's where taxing the same income may not be palatable. I don't know. Just want to raise that as a policy discussion topic. But you do see it as those income streams change. You can quickly see who's going to be paying the payroll tax, who's not going to be paying the payroll tax as much, and how that's going to affect people of different age groups on what their tax liability will be. But again, that was trying to follow up on some of the questions from last time. I will make a note to send to Morgan just some of that on the Social Security. I can put together maybe just a couple slides that would help illustrate that just to you all, and then Morgan can distribute those to you. That will hopefully help fill in that area. Yeah, John.
Yeah, I mean, would there be a circle like that for people 65 and over? Because obviously, I think we can all see that if folks 65 and over are going to participate and benefit in this, then it would be only fair that they contribute to it. And so to the degree we could get information about folks 65 and over, I think would be very helpful. I know that a great degree of wealth is in the hands of my age group. And that's a very significant discussion for us, I think.
Yeah, I will add that, because we do have published information, I think in more detail than even the 60 plus. I think we get even the detail, the sources of income as that age goes up. I think it's probably closer to 80 and up or something, where it just gets all grouped together. But I'll take a look and can add that to the list. Okay, and then I see Chris is the one other hand up that I see. Oh, and Charlie now.
Yeah, thanks, Kyle. I mean, regarding the 65 and up, I'll be curious to see what that looks like, but I'm sure we can make an educated guess, right? I mean, it'll be probably lower wages, higher retirement, interest, and capital gains, right? But I also wonder, we look at these charts and we can see, sort of a tax base that's available to us, but what kind of assumptions do we make about flight of that tax base? So suppose we were going to increase capital gains tax or increase income tax. I think it stands to reason that some of that income and some of those assets just leave the state. And so how do we make a guess at how significant that is? I mean, I think it, folks nearing retirement, I would think that, any kind of tax rate increase would factor into their decision on where to retire.
Yeah, in terms of that, it really gets into, from our estimation standpoint, gets into a dynamic effect, which is generally not part of any revenue impact statement we put on a bill, but it often comes up in discussion. So sometimes that analysis certainly does get done for some of the larger discussions. This one, I think, would be especially challenging in that you're also remaking healthcare. So just looking in isolation from a tax perspective. But I think that's a very good point, and that it's something that will absolutely get raised in front of you all as this moves forward, and depending on how concentrated any tax increases are. Because I know in some of the work that the work group did, they even, just for discussion purposes, but they were talking about tax rates in moving things up to 30% for some of those highest income folks. And that would be a very, very large lift. I mean, right now we're at 9.9% is our highest tax rate. And then we've had discussions in the legislature where you have local income taxes now in Multnomah County and imposed by Metro that are raising that up, again, getting people to the low teens, and just some of the impact that could have. So again, yeah, layering something additionally on, especially some of those super concentrated high income, there does come a point where that becomes a part of the topic of, are you going to see challenges? And I think someone in this group even mentioned that could hit some of the medical providers as well, which then has this whole ecosystem challenge of trying to get these medical providers in as well.
All right, thank you.
Charlie, I think you were next up.
Yeah, thanks. So I would also like to see some information about corporate income taxes. So I know it wouldn't be a big revenue raiser, but I expect that we will be looking seriously at a corporate payroll tax or an employer payroll tax. And to some extent, that's going to hit corporations that don't make any profit a bit. And so I think a little bit of that can be balanced by having a corporate income tax as well, a corporate healthcare income tax. So I think I would like to see some information related to the corporate income tax that so we could consider that as a possibility as well.
Cheryl, I think you're.
Yeah, I know we're running a little bit behind, but I did want to make sure we have our questions and follow up for you before you get too absorbed into the session. So I have a question for the committee really quick, again, to kind of check your pulse and see where we're at. On the sales tax revenue, if you would be supportive, how do you feel about exempting certain purchases from the sales tax, and how do you feel about the sales tax credits for certain income levels? So I just wanted to hear if this is an approach that we're going to consider, if there are certain parameters for the sales tax. But let's go with the other hands raised and just think about it, and I'd just like to know where you're at.
I think, Jeff, you were the next up.
Thank you. I was recently on this is on the people moving. Recently at a presentation from Eco Northwest. A couple years ago, inside Multnomah County, there were approximately 5,000 families with taxable income of 500,000 or more. The most recent data shows that number has dropped to slightly under 4,000. And so there definite, evidence of, if you push taxes too high, people will move.
Yeah, that's a good point. John?
Yeah, the other tax that affects people of our age is estate tax, and actually the question about that, my impression is Oregon has a very significant estate tax. California doesn't. And so to some degree, for people over 65, that tax issue, especially, let's face it, if they're wealthy, they have advice from sophisticated folks, and they know about the difference just because of the estate tax. And I don't know how much revenue the state tax generates, but that should also be in the flavor. And then Cheryl, just because of your question, I personally am very skeptical of the sales tax, and primarily because of all the administration it would take. And just setting up a sales tax just seems to me to be not my own choice. So I'm skeptical of any sales tax.
Okay, thanks, John. So with that, I think it looked like you got to your last slide, Kyle. So in terms of follow-up, I know I heard, Charlie ask about a corporate income tax, and there were a couple of other areas you're going to follow up. Do you think that's something you can send to us, or do we need to schedule you again for one of our next meetings to go through it with us?
Yeah, let me go ahead. I will put some information together, and I can
Okay.
include some of our basic stuff we have on the corporate income tax that gives a sense there. And let me distribute that and then take that as the next steps. Yeah,
Sounds good.
I know. Yeah, sounds good.
Thanks, Kyle. Okay, so we're going to move on to administrative savings assumptions, welcoming Janine Smith back to review these assumptions with us that Rand and Optimus used. So I'm going to hand it over to Janine.
Hi, all again. Thanks for having me today. Want to move on to the next slide, Katie? So our focus today is to kind of refresh and review the Rand and Optimus estimates of admin costs as you think about creating your proposal for what this is all going to cost, and then the revenue sources. And I also threw in a couple other states as well, and talk about some potential areas of savings related to why the estimates were thought of as they were then. For background, there's two types of admin costs. There's the payer side. Currently, that's the multiple payers. They all have a wide variance depending on the type of plan, and with obviously Medicare probably coming in as lower, and versus the traditional Medicare, that is, and versus some of the commercial plans and MA plans. The single payer would, of course, manage that into one plan, and the potential savings would be because of that removal of margins or profit. The less you wouldn't have all the different plans doing their own marketing and ads, and there would be some efficiencies. There's also a provider side. These are the providers that are billing the insurances currently. And those include hospital systems, pharmacies, labs, imaging entities, durable medical equipment, which is DME, and behavioral health, as well as just practicing providers. They have to have people in their offices and in their facilities to do the billing and coding. They need to negotiate and set up contracts, and there's certain legal fees, etc., to make on their contracting with all those multiple different plans. They need to manage those, the revenues as they come in, financial services, legal services. They might have consultants. And the potential savings on that side is a little less harder to differentiate exactly, but there would maybe be less administrative costs because they would only be interfacing with the universal health plan, and they would have less uninsured because everyone would be covered, and their pay would be more set in terms of pay, meaning their billing, because you probably have a uniform billing. So there wouldn't be a lot of negotiations. Next slide. there are still needs for administrative costs. You have on the payer side just implementation and transition activities. There still be claims processing. It just be one sort of central way of doing it. There would be some enrollment and member services, so to speak, by the entity itself, as to making sure that you're fit the criteria to be eligible for the UHP. There'd be utilization and management, quality assurance, population health analytics. These are all things that all these different plans are currently doing. There'd be some credentialing of providers. Again, if you're going to have all providers in the state be eligible, this may be a lesser than currently is done by individual plans, but that takes up a lot of hiring of people to do that and costs there associated with it. There would be some coordination of regional entities if you went with, and again, it depends on where the governing board lands on that, but the original task force had regional entities engaged. And then there's always preventing fraud, waste, and abuse, false claims or overbilling, etc. And then there's just fulfilling the reporting requirements and any federal requirements, since you'll be pulling in Medicaid, Medicare, and any other Affordable Care Act, such as the marketplace dollars. On the provider side, they'd still need someone to send the bills to the universal health plan, but would maybe be less of a load because you wouldn't have to be doing it to different plans. There'd still be potentially some prior authorization or other ways to manage utilization that might be required. And then, of course, any requirements at the provider level to fit with the federal and state rules and regulations, costs like interpreter services, etc., and reporting around if you had performance metrics that and doing that analytical work. So this was just a starting list. When RAND looked at this, which is again 2017, they felt that the single payer would bring admin costs down from 8.2% of overall cost to 6.4%. So there was a reduction compared to the status quo and a certain amount of savings. That savings they attributed in their assumptions due to the centralized purchasing impact, assuming there would be still be a new ASO or administrative service organization, whether that's at the state or if it's contracted with the state. There wouldn't be the plan to provider pay negotiations, less uncompensated care. But they were they were hard pressed to estimate any care management potential savings. Charlie?
Yeah, I just wanted to say that RAND did not include any provider side administrative savings. It was just the insurer side.
Right. They didn't split it out the way that you'll see here in a minute how Optimus did.
Yeah.
Next slide. Other questions? So for Optimus, they ended up about the same place at about 6% on aggregate. The task force asked them to think about it from a 4%, but they thought that was just too aspirational and wouldn't provide enough funding for some of the administrative services the universal single payer would need, such particularly around fraud, waste, and abuse. They comment about that specifically in their report. They thought they did split it out into payer and provider. They thought the administrative cost rate would go down from what they felt at that time was 9.1% to 5.8%. But they did estimate some reduction in provider costs. It was a little harder to pinpoint that. They ended up choosing about a 4% provider side savings. They thought that there was potential for higher end of savings over time. There should be a space between over and time, depending on how administratively burdensome the UHP was set up. So depending on how much requirements. Similar sort of savings attributed to the margins and insurer commissions removal, which is something else to think about. Marketing and ads, more efficiency over time. And again, not having, from provider side, not having to interface with multiple plans and payers. Charlie, do you have another comment?
Yeah, I do. So one of the potentially important provider side administrative savings is in hospitals, and a number of researchers have evidence that if we use a global budget sort of payment system for hospitals rather than a individualizing the payments for individual services, that there's substantial potential administrative savings and also potential equity improvements. So we should keep that in mind, that the design of how we pay providers is going to affect how much we think we can save on the provider side of administration.
Yes.
Thanks.
Payment does dovetail a lot with administrative costs. Next slide. So I put in, and Anya was on today, can certainly comment more about this, but Vermont had an analysis. It was a combination effort between Wakely and the University of Massachusetts. It was older, 2013. And they looked at high, mid-range, and low ranges of spending and savings, examined the literature. We can provide you with that document if you haven't already seen it. And they ended up using their mid-range in their final analysis. And they thought that it would come down to about 7% of overall costs. And again, similar about whether there would be having one payer versus multiple payer, how that would play into this, as well as what would be an efficient provider. They did not include providing clinical services more efficiently, reduce fraud and waste in their estimate. They expected those would come later, so they didn't put them into their initial first year. And I would note that they anticipated some continued employer-sponsored insurance in their model, and they were wrapping around Medicare and not necessarily bringing it in. So it is a different model. And Anya, did you want to add anything to this?
I would just say, yeah, it's a different model. I think it was what I would consider a realistic model of what a state might achieve. Which made it more complicated than what you folks are talking about at this point in time, and therefore made a fairly conservative assumption about administrative savings. You'll see Hillenstein and company estimating administrative savings much higher than 7%. But 7% is certainly in line with what private payers and public payers in the US now spend on admin. And so, yeah, we took a pretty conservative approach, but felt like that was consistent with what the governor had asked us to do.
Questions? Okay, next slide. And this is just a little more detail about the Vermont analysis. Just shows you their sort of low, mid, and high estimates, ranging from 14% all the way down to 4.8. They also have it. I thought it was nice that they had outlined sort of what the status quo spending was for physicians and for hospitals. They kind of differentiated. And then what they estimated their reduction. So it's like 38% reduction of that 10% of revenue. And so just to help you understand that table, but that was their thinking that they would be different on whether it was a hospital or other providers. Again, we have a copy of that and can make sure that's available to you all if you want to take a look at that for further background. Richard?
Yeah, I didn't really understand what 10% of revenue refers to. Is that an administrative cost that could be saved, or is that, I just didn't understand this table.
They thought it was 10% of the revenue was administrative, the low estimate. If we just took that first row, that was what was being, 10% of their revenue was being spent on admin by providers.
Okay.
And then if you had single payer, there'd be a 8% reduction of that 10%. And then the hospital spending at status quo was 4% of their total costs was attributed to again, these are low estimates, admin, and then 33% reduction, or a third of that would be reduced. And that's when they built their model. They used Jonathan Gruber's model.
I just want to make sure I'm understanding the numbers right. So the mid-range estimate is stating that physicians and other providers spend about 14% of their revenue on admin, and that they would experience an almost 50% reduction in that overall admin, or just in billing and insurance related costs?
They did not distinguish that there. I'd have to go back and double check, but
okay.
Yeah.
To me, that sounds like an extraordinarily high reduction in admin for providers.
Yeah, I think it's, they just didn't repeat the billing and insurance related costs in the two rows below, but I think it's meant to be that.
Gotcha. That makes sense.
More questions? Okay, next slide. And then Washington State, I worked on with them at this point. The Optimus was doing modeling. They came in, they thought it would come down as well in a single payer model. They had two models. They have a solo single payer that they asked Optimus to price, and then they had one where it was partially managed by plans, and they thought that the payer side could come down to 4.5% of premium if it was fully single payer, but they'd need to, because of the plans engagement in it, it would be a little higher at 7.5%. Provider administrative efficiencies, they thought status quo was 8%, and then they included a sort of an aggregate decline of anywhere from 0.6 to 2.4 that would increase as the program matured. They felt that savings was not just solely due to less payers, but the volume of prior authorization requirements and reporting burden could also contribute, depending on how the single payer was applied and the requirements they would have to produce. So that was reduced payer admin costs, the increased purchasing power, the healthcare provider administrative efficiencies, and then program integrity improvements. All that would work towards getting the lower admin costs. Then they thought there was an overall savings of $2.5 billion. So in general, so for Oregon, the RAND and Optimus studies come in at around 6%. There's the payer aspect of this and the provider aspect of it, with the provider side being a little more difficult to assume, immediate savings, and probably a more gradual shift, depending on how the single payer is administered. We touched on this already, the sort of sources of where those savings would come from. Next slide. Other considerations that was noted in these analysis that I just bringing to your attention, that you continue to need admin services to maintain your compliance requirements for the federal regulations for the various different populations, program integrity, monitoring fraud, waste, and abuse, And and some currently believe to contribute as much as 25% of total healthcare costs, but are lessened by the decreasing fragmentation, was how one of the studies put it. Some savings may accrue only over time and not be there initially, and that provider side savings are harder to estimate, and the rates to be paid also influence this side of potential savings that can be expected, as per Charlie's earlier comment. I think that's it, unless I have another summary slide. Next slide. Richard?
So I'd ask Chunwei, does this sort of administrative savings seem in the right ballpark? Because I'm impressed. I mean, looking at the billing staff at the hospitals, it's really, really high, the amount of staff that they dedicate. All these numbers seem, I think, a little low. Plus, there's a wide variation. But I asked Chunwei, in your experience internationally with single payer plans, what can you comment on these proposed savings?
Yes, my observation is those estimates are taking a very conservative approach. As you mentioned, that if we compare with other countries such as our neighbor Canada, their bidding department compared with the US is just a small fraction. Usually, in the previous estimate for hospitals with comparable size, US generally require more than 10 times the personnel to do the billing. And so my observation is this estimate take a very conservative approach.
John?
Yeah, boy, am I ever in that camp. I think these, from a provider side, are very conservative. My own personal experience in my 5 years at Open Notes, and Richard was in this same environment. Absolutely every health system we worked with would say, now we'll do Open Notes, but our number one priority is the revenue cycle. When we would talk to programmers, the programmers would say, our priority, our manpower is all in the revenue cycle. I'm not sure, for example, that these estimates include the hours that providers are spending in the evenings, essentially responding to billing folks' suggestions about changes in coding. There's some estimates that 10, 12, 15% of their time is spent on revenue cycle issues. And I doubt whether these estimates include that portion of their salaries. Katie will send an article around that appeared last week in JAMA. Now, it's a viewpoint, but I think from a credible source, folks at Stanford, Chunwei may know some of them. Now, I'll warn you that it's a challenge to the Trump administration to take on administrative costs in the system. But let me read just a couple. As you just heard, in the first paragraph, the US spends approximately 10 times more on average than any other OECD country. It's estimated that 2/3 of these costs are related to transactions or billing costs and insurance-related costs. In the US, a primary care physician spends $20.49 to receive payment for a service that generates approximately $100 in revenue. They go on to talk about the potential to save billions of dollars. They mention one study finds that prior authorization alone annually consumes an amount of time equivalent to the annual working time of 100,000 registered nurses. 100,000. And in last week's annals, there was a note from a quote patient. It was written by two clinicians at Stanford. And it described the difficulties they had had around pre-authorization for their 3-year-old son who had an eosinophilic esophagitis and needed an expensive drug. 9 people handled that pre-authorization. 9 people. None of them had any expertise on the condition that the child himself had. Clearly, the easiest thing to do was to just say no. It's extraordinary what's going on around prior authorization for some insurance companies. You know, I believe others are much more ethical and responsible. But I think we have an obligation. When you are raising revenue, I think you're obliged to do everything you can to make sure that what you're raising revenue for is efficient, is appropriate. So I think this is a huge issue. I think, frankly, I think it's a $5 to $10 billion issue. I'm going to be very uncomfortable communicating to the board any kind of estimate on revenue until it's clear to me who's going to help figure this out. And might I say, the only way we're going to figure this out, I mean, I think Janine's done a great job of describing what's out there. The only way we're going to know is to get folks who do know what's going on in that revenue cycle in the back of those offices to sit down and talk with us, and to do so in a productive and transparent way. I know that's going to be hard, but I think there's folks in Oregon who will do that. So we can actually get a real world sense of what's going on. Thanks.
I think Cheryl or Chun-Hee.
Yeah, I just wanted to double down on John's sentiment about the administrative costs and say that for the behavioral health system, it's further magnified because there are a lot of things in the behavioral health system that we have to do that the primary care, physical health care system doesn't. I mean, including not just different forms and reports to different payers, but also all the documentation requirements, all of the requirements that we have to then pile on to the clients we serve before they even get any care. I don't even know how to measure that as an administrative cost because it's really a cost to the people we serve that they're not getting the care that they need right away. So there's that. So I would agree that this is a conservative estimate and we need to really fine tune that estimate and get it closer to accuracy. So I like John's suggestion.
Shunwei.
Yes, I fully concur with John's comment. And in those estimates, at least 2 important issues might have been neglected. One is over the last 2 decades, private insurance has started a new practice. That new practice just last December become more visible with the assassination of the CEO of United Healthcare. That practice was to deny legitimate claim. And with that incident, many media reported the current practice. The industry average is about 15%, meaning about 15% of legitimate claim were denied. And the rationale for doing that more than 2 decades ago when this started was they did an actuarial estimate that for every 10 legitimate claim you denied, on average about 3, that's 30% or so, will appeal. And then when they appeal, you just pay off. So you make the profit from the 70% that did not appeal. And one time I was teaching this in my class, and one student raised her hand. This was a graduate class of healthcare system. And this student raised her hand, said, Dr. G, and she said to the class, this is my current job. Her current job was hired by insurance company, and her full-time job was to deny legitimate claim. And so I suspect this issue was factored in those estimates. And the denial of legitimate claim not only increased the profit, but also, so far I haven't read any estimate. How does that harm our population health? And in the end, that incur more healthcare costs. And that will be very complex to estimate. And then the other issue that those estimate probably either neglected or took a very conservative estimate is when we are on a single payer system, all benefit will be uniform and all payment system will be uniform. And that make it very easy to do electronically. And I'm using Taiwan as an example. Taiwan did complete online claim and online payment. And Taiwan's universal health care probably among the world's fastest to pay providers. That if you file online, you get your payment within 15 days. And I think few payer can pay that fast. And this is because the same issue. Every patient are on the same benefit package. And every provider are paid on the same method of payment. And that for both sides, from the payer side and from provider side, that will represent a very dramatic change in efficiency in terms of administrative costs. And I suspect that part was seriously considered, and those estimates took a very conservative approach.
Chris?
Yeah, I think that's a really interesting point, and it makes me wonder the extent to which the actuarial estimates incorporate some kind of assumption about spending that's suppressed using these kind of denial schemes. Because if this is pervasive, especially on the commercial side, I mean, that would suggest that spending on services is understated. If the actuaries were using, say the all payer, all claims database to, to build up an estimate of healthcare costs. So there, I don't know how they handled that or what kind of assumption they made, but something to think about. I think, how efficient the universal health plan is, it depends a lot on how the state plans to run it. I would suggest that the CCO system is very administratively complex compared to less regulated insurance company. And if a lot of those practices and policies and programs are carried over to a universal health plan, we might see similar costs and complexity.
Other comments? John?
Yeah, I mean, I think what Chris has just said is incredibly important. And I mean, isn't it interesting that here's our CCOs taking care of a population that in general is paying a price half that of commercial. And they're dealing with these very significant administrative expenses. And they're still figuring out, how to survive and get this done. And for a variety of reasons, I think it's admirable that CCOs have reached some degree of stability. But it would be interesting to sit down with those CCOs who would be really willing to have, this kind of transparent conversation, and find out how much really could we get done, and then be conservative and go back and not quite get there, but then really look at what the revenue implications would be. They would be enormous. They're going to be enormous. Thanks.
Any other questions or comments? I'd be curious to know what the next step is then, if we need to fine tune the assumptions or estimate on the administrative savings. I'm not sure how we do that. I know, John, you talked about meeting with people who do this work. I mean, is that something that the committee does? Or, I mean, how do we get to a more accurate estimate of administrative savings? That's a question for the whole committee, and for Janine too, if you have any thoughts.
Well, my own, I think we should have a discussion here that's devoted to that and come up with a plan. I think that the comments I've heard, for example, about how will we pay providers, that's number one on the list. Because if we can figure out a way to pay providers in which the two parties have more confidence and trust in each other, and get rid of all of the checking and other kinds of systems that are going on. You'll see in this JAMA article what the Stanford guy throws out to the Trump administration. If you really want to be efficient, let's get one format for business transactions. There's multiple formats for business transactions. It would save an enormous amount to have one format. And of course, as I read that, I thought, hey, we can do that. We could do that.
So it sounds like, John, we need to devote at least another meeting, if not more than that, to administrative savings on how we develop a plan to get to that more accurate estimate.
I think so. I think that's the next step, is let's devote an hour or two to this, and start to develop a plan and see then where's the board want this to be. We definitely need to be doing this in concert with the folks negotiating a provider side reimbursement and payment system, and with the hospitals.
Yes, thanks, John. What about you, Chris?
Well, I guess I'm thinking about some of our previous conversations about the scope of this committee and what we're meant to be working on. I know the plan design committee will be making a lot of decisions that affect the cost of this plan, and I wonder if that's the right forum for adjusting the financial estimates. I mean, if our primary goal is to create a set of revenue sources that can be adjusted, tailored to the particulars of what the plan design group comes up with, I wonder, are we really adding value by spending a lot more time trying to refine the estimates that the actuaries made? I mean, I don't feel more qualified to make those estimates than the actuaries, certainly.
Wonder too if that's something that we can get help from by the revenue. I don't know what they're going to be called, but the revenue consultant that comes out of that RFP. I don't know if that's something they can help with. Charlie?
So I'm going to put out a sort of a dream kind of a meeting that I would hope we could have at some point, and that it would include some people from Canada who know the this is about hospital expenditures and administration, I guess, in particular. Some people from Canada who know what they do in paying hospitals there. Some hospital executives or CFOs or something, somebody from hospitals in Oregon who know what happens here within hospital administration and hospital administrative costs. And the plan design committee and the finance and revenue committee, and all of us meet and have a serious discussion about what could we do in Oregon to get to an efficient way to pay hospitals, and would that hospitals could accept. And it may take more than one meeting, but it's to me, it seems like the discussion needs to be amongst all those sorts of people. Otherwise, we're probably not going to get to where we need to go. But I know that's going to be a really tough thing to pull off, but that's kind of my dream, I guess.
Yeah, and I would just say, having been on the plan design committee, we didn't, I mean, not that I recall anyway, we really didn't approach administrative savings at all. So I don't remember a discussion about that at all yet. So Janine, do you have any thoughts?
Well, I do think that you're going to have more partners. You'll have a revenue consultant that will help with, as you think about the revenues structure. But you also will have actuaries, because there's a second bid gone out for that, to work with you on the details. But I think you have to be realistic that it's not something that a lot of people, that there isn't magical numbers we're not showing you, because there aren't perfect numbers anywhere. Exactly. There certainly is other experiences, but not necessarily exact numbers. And so I think it's a matter of and what you have right off is not going to be necessarily what you will have over time. I mean, if to put in some of the streamlining and efficiencies that'll get you more provider savings in an admin will take a while. So it won't be there year one. Everyone's operating the current electronic stuff. You all know how long it takes IT systems to change. So I think you might need to come up with an estimate. And then, as per Chris, as the other committees get their work done and the governing board gets their decisions made, then you'll need to refine it over time. So I think there's lots of room for refinement going forward, which in order to get a proposal going, you may need to land on something, working with the actuaries to get going.
That's really wise advice. Thank you. Richard?
Well, like Chris, I'm reluctant to just throw out what actuaries and national consultants have done. At the same point, it doesn't seem to fit with for those that have been inside of healthcare. So I think we need to do a bottoms up approach too. And I'd love the idea about bringing in people from Canada. I'd say not just on hospital, but I also say on physician group billing, because that's a big part of the expense too. I mean, hospitals are 30%, physician groups are 20%. Those are the big two. So we need to bring in people that know that. A couple more things is, ultimately, we're going to have the budget for Oregon Health starting with 2023, ultimately going up to 2030. And at the bottom, we'll have some fudge factor that can be applied in terms of administrative savings. So I don't think we can always say, is it $2 billion? Is it $4 billion? But we'll apply that to the overall money that we need to raise. And then the final thing I would say is, I think it's incumbent upon either the plan design, but really more on the finance and revenue, to give a view of how billing will go with providers under the single payer plan, because we'll have to win over providers. We have to win over a lot of people. We have to win over business, the consumer, payers. I don't think we'll ever win them over, but we need to bring over the providers, and we'll have to have a clear way of saying, instead of doing all this prior auth, instead of having all this billing personnel, you have a single rate list, and here's what you'll likely need to do. So I think we'll need to paint a picture of what it'll be like for the provider under the single payer plan, so that providers know, one, will that be reasonable? And number two, how do we expect to achieve the administrative savings that we may claim? So thank you.
Yeah, thanks, Richard. And I just want to say, just from my observation of serving on the plan design group and on the board, I feel like everyone's waiting for us to propose something, and then they want to react to what we're proposing. And like Janine said, we start with something and there's room for refinement. That's how I view it. I do want to check though with Morgan if that's how you see it as well. I just don't see the plan design group delving into these types of details at all.
Yeah, thanks, Cheryl. I think that that is very wise. Clearly, there is interest from the committee to continue to work on this, but I think the way Richard laid out the spreadsheets that Richard and Charlie are working on, to start with some estimates so the committee can focus on diving into the revenue discussion and continue to refine the revenue options and continue to look at the administrative savings ongoing, I think is a really smart way to approach it, because I do think the other committees, plan design in particular, are looking for that overall revenue plan and the revenue options in light of the joint meeting that the two committees want to have in July. The committee really needs to come up with that revenue plan by June. So I think that there still can be some adjustment. The other thing that I would add is that I do think the plan design committee will be looking at provider reimbursement, not in February, but in March. So at least in that, how providers are paid, that is one of the things that is in the plan design and expenditure committee's purview. And maybe, I hesitate to say this and try and jam things up, but maybe something that there's a future joint meeting together in, but will be, I think, a thing that we'll want to make sure finance and revenue is very aware of the conversations that are happening at plan design as they dig into that topic as well, to make sure that there is that communication between the committees on an issue that both committees are interested in.
Thanks, Morgan. That was really helpful. I know we're way past time for a break, but I do want to give Anya and John the last words, and then we'll take a very quick break.
Thanks. I just wanted to reiterate or, pile on about the need for coordination with the plan design committee. Because I think if you're making assumptions about how costs will or will not be controlled, and they're making different assumptions, those two are not going to add up very well. I don't think cost control has been the focus of any major discussions I've heard in this process so far, but you'll have to face that. And the question is, are you going to control? The way I think of it is, are you going to control on the supply side, which is what a lot of countries, including Canada, do, really simple administrative structure, but less access to services because they just don't allow services to proliferate as much. Or are you going to control, and price controls are another example of how you could do that, which may be implied in your conversations, but I don't know that it's been sort of explicitly stated. And then on the demand side, are you going to have controls like utilization management and cost sharing? So far, the plan design committee has said, no, we will not have either of those. And so, actually, I think around utilization management, there's still some discussion. I shouldn't say that. Around cost sharing, they've definitely said we will not have that. And so need to make sure these fit together so that whatever you're assuming will go away in terms of administrative costs is consistent with what they come up with.
Thanks, Sonia. Good points. John?
Yeah, just two quick things. I don't want to put an increased burden on Chun Wei, but Chun Wei is an incredible expert when it comes to this, as he said before. He really knows his stuff, especially about what's going on in other countries. I hope he'll be willing to, help keep this on track. And the second thing is, there are very credible people in Oregon who are focused on how the back office of physician practices work. Now, they have restraints. They have to be careful about, what they reveal in terms of some of these sorts of things. But there's resources in our own state. The question is setting up an environment in which they will feel comfortable being cooperative, being constructive, and really helping us get to a, if you will, ideal. And then, adjusting backwards from that. And I loved Chris's comments about the CCOs. If there's a subset of CCOs that we could have that discussion with, and knowing that they've got relationships with OHA and all of that, that's what we need to do. Thanks.
Thanks, John. I think maybe we put in one or two too many very weighty topics today. So we're running a little late, and we'll have to probably revisit several of these. So we're convening at 11. So have a nice little break.
It is now 11 o'clock, so Cheryl, feel free to resume when you are ready.
Okay, thanks, Katie. So we're definitely behind today, and ERISA is a very big topic, so I'm going to ask that we condense the time to talk about ERISA with the idea that we're trying to identify questions that we have about ERISA. So we're not really getting into all of the issues related to ERISA today. So if we can make that like 15 minutes, and then so Charlie has 20 minutes for health expenditures, then we can get into the meeting reflections, next meeting, and public comment. Just I don't want to short shrift any of the other things, including the public comments. So with that, I'd like to welcome Jenny to provide a very brief overview, and then help us to identify other questions that we might have about ERISA to be discussed at another time, not today. So I'll hand it over to you, Jenny.
Great, thanks, Cheryl. So like Cheryl said, I'm here to provide a high level overview of what ERISA is and some of the components, questions, and challenges that you might start thinking about to develop other questions that are going to dig a little bit deeper into ERISA. Katie, go ahead to the slide. So the board had a presentation on ERISA by two ERISA specialists. There are attorneys and scholars who dedicate their entire careers to ERISA. Points of it, and stay around to listen to some conversation if you have a little time today, and note the questions that you have moving forward. I'm also getting a note that my internet connection is unstable, so if I freeze or you can't hear me, I'll go ahead and turn off my camera at that point. Okay, so ERISA is a federal law that preempts states from directly regulating employers' choice in whether to provide benefits or the plans employers provide. So what does that mean? It means that a state can't tell employers that they may not provide benefits, and it can't tell employers that they have to provide a specific type of benefit or that they cannot provide a specific type of benefit. Essentially, what the law around ERISA says is that it preempts states making laws that relate to private employer-sponsored benefits. And so there are a lot of exceptions to that. There's a lot of case law around that. And so they're really looking at what case law says is that they're really looking at laws that act explicitly on those plans. So states may regulate insurance providers, thus having some regulatory influence on plans purchased by providers. The examples that are provided in the memorandum that you received as part of your materials for this from Professors McCuskey and Aaron Fuse-Brown do note that a state could prohibit an insurer from offering a plan that would duplicate a universal health plan. So the state can act on the insurer to do that, but they couldn't act on a self-funded employer, an employer who provides its own insurance coverage and bears the risk of those claims from providing a duplicate plan. So self-funded plans may not be regulated by states. So those are like I said, the plans that are provided by employers where the employer assumes the risk. And so if the state decided to regulate the insurance provider's plan, that could affect what insurance plans that are offered through the market, not self-funded, would be able to offer. And that would not, they assume, preempt, or that would preempt an ERISA challenge. But if a self-funded employer decided to do the same, the state could not regulate that for them. Another way to get at whether or not employers would be encouraged to participate in a universal health plan, even if the state hadn't preempted insurers from offering those plans, is looking at provider reimbursements and how provider reimbursements are regulated by the state. So they could allow providers the choice to only contract with the state plan. If providers had the choice and were not mandated of doing so, that would not necessarily, and again, this is something where case law can go back and forth and it isn't really settled, but they assume that this would not make an ERISA challenge successful if the providers were given the choice. If they were mandated to only interact with a universal health plan, then that could preempt, or that could provide a preemption that could provide an ERISA preemption due to the fact that other benefit plans in the state would have no providers. But if it was a choice on the provider's part, then that wouldn't necessarily provide that ERISA preemption. So for financing a universal health plan with a payroll tax, the professors found that it's very likely that this would be permissible under ERISA because the states can do something that affects the employer's ability to provide the plan or affects whether or not people would want to join the plan. So a payroll tax does not directly relate to ERISA because an employer could decide to still provide their own plan and pay the payroll tax. The idea would be is that it would be more attractive to allow their employees to join the universal health plan rather than providing their own plan. So what the courts have looked at is whether or not those types of taxes could be considered exorbitant. Exorbitant has not been defined by the Supreme Court in looking at these cases, and they have found in a previous case that a 24% surcharge on commercial insurance claims to hospitals was not exorbitant. But when the professors looked at the Joint Task Force plan of the 7.5% tax and the 10% payroll tax, they assumed that this would likely not be preempted by ERISA either, because this is not likely to be considered by the court as an exorbitant tax. But again, this isn't an area that's been defined by the courts yet in terms of what they would say exorbitant is. There's case law from Washington State and from San Francisco, where in Seattle, they had employers paying an extra tax. I think it was around $400, and something similar in San Francisco, where the court also found that that wasn't exorbitant and was not preempted by ERISA. And that was the lower courts. The Supreme Court did not take up that case. They did not. It went to the Ninth Circuit. The Ninth Circuit said that the state law stayed, and the Supreme Court decided to not hear the case, allowing that lower court's ruling to stand, that that amount was not exorbitant. And so, though the Supreme Court has held that the payroll tax is not a violation, it's uncertain to understand at this point, depending on what the work of this committee does and what the tax level would be, as to whether or not a challenge by an ERISA challenge would actually be successful. We did learn from the presentation to the board that there is an entire sort of litigation component set up within the insurance community to provide ERISA challenges based on whatever law a state brings up. So whatever the universal health plan law could be, it would be likely to be challenged by ERISA. The fundamental thing is whether or not that challenge would be successful. And looking at what has been suggested by the Joint Task Force at this point, and whether or not the Plan Design Committee and this committee takes up some of those recommendations and looks at some of the same options, would probably determine whether or not one of those actions would be successful. I know that's a lot of information and a very high-level overview. I'm happy to take and note down your questions so that we can come back and get into ERISA a little bit more specifics on ERISA at a future meeting.
Thanks very much, Jenny. Does anyone have a question that or an issue that they want to dig into more to help develop a recommendation? Chris?
Yeah, so I mean, it sounds like one of the constraints we have is, whether or not a tax is exorbitant, but that's not defined for us. And so How do we think about that with respect to a payroll tax? Like, where should we place that upper bound?
Thanks, Chris. Richard.
I think going through the 7-page document that was provided ahead of time, again for us, very, very helpful, very, very dense. I think one of the decisions this group will need to make is, what about providers that see patients outside of the universal health plan? Because that could have a big difference in terms of whether our plan is accepted by providers down the road. So I think that's a decision that's going to come to us. Will we allow providers to see patients offering the same services, but do it, do they commit fully to the universal health plan and not allow to see patients outside of that or not? I think that's going to be a big issue for us.
I wonder too if that's not a plan design or part of the plan design recommendations. I don't know. Is that in our purview here of this committee? I don't know if Jenny or Morgan have thoughts about that.
That seems outside of the scope of this committee, more just because of the focus on finance and revenue and developing that financing plan. But I will say there are other elements of interaction with providers that is currently in the plan design, provider reimbursement, and they've also in their work plan is discussion of workforce, quality of care. I don't think that this particular question was in their work plan. So I think it's a good thing to call out and make sure the plan design committee is aware and building that into their work plan. And I think this is that communication back and forth between the committees that we were just talking about and how important this is.
Yeah.
But I make the case that it's also got a financial component to it, because if people are going to be, if providers are going to have to bill more than just a universal health plan, that diminishes the administrative savings we might get over.
Yeah, for sure. Thanks. John?
Yeah, first of all, I'd like to make sure that we all appreciate something that wasn't stated. ERISA does not apply to public employers. So we can engage public employers now in a conversation and get feedback from them. In fact, if public employers aren't going to be supportive of where we're going, then we've got work to do. I think that's really important. Again, like the last topic on administrative expenses, there are Oregon resources. There are business folks who I think would work cooperatively with us, but you know, it will take creating the right environment to do so. And based on when I was on the task force, I asked a business person who I have confidence in, and you should just know that when ERISA comes up, most business folks say all ERISA issues involving self-insured employers end up going to a /law firm, think tank, interest group in DC, that their whole life and task is focused on ERISA issues and defending self-insured employers when it comes to ERISA. And so the ultimate test will be, I think, asking them, what do you think of where we're going? A tricky thing to do, but again, if I really think that this has been great work that the task force did, and now the governing body is taking up, and so it's a really important area.
Yes, certainly. Charlie?
So the other group of ERISA protected, I guess, insured people are multi-state, multi-company union plans or Taft-Hartley trusts, and it would be, I think it would be useful to maybe get some information on how many people in Oregon are covered by such plans. I mean, we can get a pretty good idea from data about the self-insured plans. DCBS has the numbers at least. No, I mean, we can't get much about financial information, but we can get at least enrollment. But the Taft-Hartley trusts and other sorts of union plans that might be covered by ERISA, it's harder to distinguish what those numbers are. And maybe it's in the DCBS enrollment reports, but it would be nice to find out how we would identify that. So that's, I guess, sort of a question, potentially for DCBS, but also just a general overall thing that we need to be aware of.
Thanks, Charlie. Well, hopefully Jenny can take that back and just check. So with that, I think we need to move on so that Charlie has enough time to present an update. So thanks, Jenny, for that overview, and we'll for sure have to add more, probably at least one discussion, if not more discussions on ERISA to get there, to future agendas, that is. So I'm going to then ask Charlie to provide an update on where we're at with the healthcare expenditures work. And just remember the heads up I gave you at the beginning that the board has asked us for a straw proposal on these healthcare expenditures. So I want to figure out what that would look like too as we're moving along. So go ahead, Charlie. I'll hand it to you.
Okay, so the more detailed work I did since the last meeting that is presented in the slides is just on a few items. And so if you go to the next slide, we'll look at that. So one of the things that came up was a question about what's personal health care, and what's health consumption mean, and what does the national health expenditure totals mean? And so this slide is just there to give a identification of that. So for our purposes, we need to be concerned about everything that is in the personal healthcare or PHC portion of the national health expenditure accounts. I think we also need to be concerned about, well, we do need to be concerned about the administrative and net cost of health insurance portion. So that's part of health consumption. And also, I think we should at least be trying to document the government public health activities, which is also part of health consumption expenditures. And then for the parts that's outside of that, we should make attempts at expenditures on structures and equipment to the extent that we can. We don't need to worry about, in my view, the non-commercial research. And so I will be trying to make estimates for pretty much everything that's on there, except for the non-commercial research portion. And some of the other pieces of personal healthcare expenditures, we probably don't need to worry about, and we'll get into maybe some of that at some point. And I've already mentioned that likely the Veterans Administration and Indian Health Service piece of that, we aren't going to have to worry about very much, but we probably will have an estimate just hanging around anyway. So if you go to the next slide. So among the items that is modestly substantial that I have been wondering about for a while is other private revenues. That's one of the categories in the national health expenditure accounts. And in this slide, I've tried to make estimates of the other private revenue expenditures in Oregon. And the largest chunk is non-patient revenue. And so it's hard to know what that's going to end up meaning for, what part of that are we going to have to replace. But so I've broken it down into sort of four major parts: the contributions, gifts, and grants received, which is roughly 25% of that total. That part is likely to be affected by this plan we want. And so we may have to think about replacing most of that with taxes, and we may not. So that's something, it's unclear to me on that, but others might have ideas on that. The provider investment and property income is probably only about 10% of that. That is mostly from hospitals. And we likely probably will not have to worry about that one way or the other, but again, I'm not sure of that. And then there's another chunk that's even smaller, maybe 5% of the total, from auto, property, and casualty insurance companies, that the health care portion of what they pay out. And again, so that particular number is actually not an Oregon specific number. It is imputed from national values, but I expect Oregon is probably similar. So again, it's a pretty small number. It's with probably in the noise of revenue we have to raise or not. I expect that the single payer plan, a single payer plan or a universal health plan would affect how much they pay but it may not, because we may want to say, if you have some liability there, it should be paid for some other method. So again, I would say it's a sort of potential decision, but it's a pretty small one, and it's almost in the noise. The biggest chunk, almost half of it, is other non-patient revenue. And that's hard to figure out what we need to think about replacing there. Some of that could potentially be double counted, in the sense that some of it comes from other providers paying for services to another provider, because the first provider is funded. Let's say Kaiser, for example, gets an amount. They're supposed to cover all the health care for the people that are members of that have their insurance, but sometimes they pay for another provider, and so that to provide those services. And so that's part of the other non-patient revenue. But other parts of non-patient revenue is like a hospital's cafeteria, or every once in a while they have some other businesses just so they can make a little money. So I would say all of that is a little bit hard to identify what portions of it we're going to need to replace with new state taxes, but it's something to keep in mind. And so we could go to the next slide. So this is a definition. Most of it is copied directly from CMS about what's meant by long-term care. So long-term care actually includes a few pieces in a broader context, some of which is often just called custodial care, and other portions which is called post-acute care. And that's what the last paragraph is just sort of my explanation of trying to say what the difference is. Sometimes it's the same care, but it just happens to go from being post-acute to custodial because the particular insurance plan that's covering that care says that's the limit. You can only call it post-acute up until this point, or sometimes it's called medical long-term care. And then after that, we aren't going to cover it anymore, and we'll call it custodial. So in some respects, it's a somewhat artificial distinction, but for the most part, it is post-acute, and it is long-term chronic, I guess, chronic long-term care. So both of those are considered long-term care, and I've tried to break it out to the extent I can. So if we can go to the next slide. So again, I should go back to why I'm trying to break it out. So one of the questions that still hasn't been decided is the universal plan going to cover long-term care? And usually, well, what I expect that's meant by that is the plan going to cover custodial long-term care? Because I can't imagine that it's not going to cover post-acute, what's called post-acute long-term care. Currently, private insurance companies, Medicare and Medicaid, all pay for that, and people pay for some of it out of pocket as well. But I would expect that even if the decision is made, as the task force did, to leave long-term care as it is, there will be parts of the post-acute portion of it will probably still be covered by the plan, and it's only the custodial portion that won't. So this slide, I won't go through all the details, but it's an attempt to look at all of long-term care, the part that's not post-acute and the part that's post-acute. And you can see overall about 15% or so of long-term care is post-acute. And then I also break it out by Medicaid, the Medicaid portion of it and the non-Medicaid portion of it. And then the last breakout is what part is home and community, what part is nursing facilities, and what part is care management. So among the interesting numbers, I wrote out that 62% of all long-term care is financed by Medicaid. And in Oregon, 68% of all long-term care is home and community portion. For Medicaid, 75% is home and community, and for the non-Medicaid portion, about 40% is home and community. So the majority of long-term care that is not Medicaid is actually not home and community. And so we can go to the next slide. So this gives information from not just, well, it has some from MBS, but it also has some from Oregon DHS, Department of Human Services budget. And so these are approved budget numbers, not necessarily actuals, but the actuals aren't that far off from the approved budget. But a slight majority of the long-term care is from Human Health and Human Services, or Department of Human Services, I should say, is for aging and people with disabilities. So 54% is that. And then the intellectual and developmental disabilities portion is about 46% of what comes from DHS. And so that kind of gives you an idea of where it's coming from. These most of what DHS provides is for Medicaid. And so it's accounted for in the Medicaid portion, but there is a little bit of non-Medicaid in the DHS provided long-term care budget. And it's a little bit hard to decipher what is not Medicaid, but pretty much the difference between the DHS approved budget and the total biennium budget right above, that amount is probably the non-Medicaid part. So you can see the numbers in 2021-23, it looks like 93% of what they provided was for Medicaid, and so 7% maybe is non-Medicaid. That's my best analysis of those numbers. So if we go to the next slide. So this just compares national totals in 2021 to Oregon totals of where does the money come from. And in general, in Oregon, it looks like more of the long-term care dollars come from Medicaid than they do nationally. And it pretty much takes away equally from the other programs that provide, or the other funding sources for long-term care, relatively equally taking away from that more of it comes from Medicaid and less from everything else. The out-of-pocket in Oregon for long-term care looks like it's about 11% of the total expenditures, and nationally it looks like it's 14%, for example. And all of these numbers, well, so the Medicare numbers especially include post-acute skilled nursing facilities. That was a special comment in the Congressional Research Service report. It's not clear whether they do, whether those national numbers include post-acute skilled nursing facilities. The Oregon numbers do, to the extent that I can decipher what's going on. And if we can go to the next slide. Oh, that's it. So I guess that's what I have to say. If anybody has any questions or maybe comments and clarifications, that'd be great. Thanks.
I do have
Well,
a
I should-
question on your Medicaid numbers. Do those include the state portion of the match?
So those, if we can go back to that slide, and back up the one before that. So, this slide does not include what's from the state and what's the federal numbers. So this is everything. In the actual spreadsheet, I do break it down into what is the federal share and what is the state share for each of these pieces. So there is more detail in the spreadsheet itself that tries to break out what's the federal share and what's the state share. But yes, these numbers do include both the federal and state share, and I try to break those out. Well, I actually try to break it out into federal share, state share, and out of pocket for each of these categories. And I think I've done that in that spreadsheet, but I'll have to check and make sure that I've done that in all these cases. So
Okay.
yeah.
Thanks for all your work. And it's not surprising to me that Medicaid is a big funder of long-term services and supports. I would say most of the people who receive care, those who have intellectual developmental disabilities are Medicaid eligible. And there are some examples of people who aren't, but they do get services through a 1915K waiver for those families who don't qualify for Medicaid. So I don't know if that's all in here somewhere, and maybe that's
So in the spreadsheet, I do include particular numbers for 1915K waiver. The numbers come from Medicaid for the total amount that is spent on that. I don't think I have any breakout of which part is for IDD and which part is for APD, aging and people with disabilities. But you can look at the more detailed spreadsheet and sort of let me know what other information you might want to try to have. Sometimes I may or may not be able to get it, but there's quite a bit of detail in the spreadsheet that's not on the slide. So
yeah, and I don't know what this will mean in terms of total cost, but our state is opening up those K-plan services to people with behavioral health disorders, are opening up HCBS. They're expanding the use of 1915I. I don't know what that means in terms of total budget. I could probably find out.
Yeah.
John?
Charlie, thanks so much. I mean, looking at these, my sense is you're mostly focusing on long-term care issues that are paid by Medicaid or Medicare. Is there any estimate of long-term care expenses that are paid privately?
Yeah, so I used the cost growth trend data to get details of what they have for expenditures long-term care. So the data exists for 2018 through 2022. And my assumption is that all of that is post-acute long-term care. And there is breakdown of what's spent by commercial, Medicare Advantage, and also Medicaid, and also which part of Medicaid is from the CCOs, which is part from the open card portion of Medicaid. And so that detail again is included in the spreadsheet, and I do try to come up with overall estimates again of what is out of pocket, what is from Medicare, what is from commercial. And so all of that is again in the details in the spreadsheet. And most of the, well, a big chunk of the things that aren't Medicaid is for post-acute, and the post-acute information is what I got from the cost growth target data.
Yeah, I mean, I don't think cost growth target can track the private pay that's going on in long-term care, which is
No.
substantial. I mean, it's huge.
So I made attempts to do that, and so you can look at the spreadsheet and see if you have other questions. I made attempts to estimate that in a variety of ways, and so some of it is imputed from national values, I think, but
Okay.
it is in there to the extent that I can decipher it. Yeah.
So thanks for all your work so far, Charlie, and I know Richard also has helped. I appreciate that. I think for now, we're gonna need to move on, but I do want to make sure I understand, or if we have common understanding of what that straw proposal would look like. And what I'm thinking as I was looking at your work, Charlie, I suppose it would be some assumptions or recommendations of what we should include in the expenditures to build our revenue plan. And, you know, including things like, that chart that you did for what is PHC, what's HCE, including all of those categories. And this issue that has been, you know, a burning question since the task force days is whether to include long-term services and supports. So that seems to be part of the straw proposal, but I do want to just get your feedback on if that's how you see it too, and I'd like to hear from Morgan as well. Charlie?
Yeah, so actually, the other piece related to the work I've done is I've got some questions that I would like to bring forth to see if the committee is okay with asking these questions. I think I have some OHA questions, I think, and I have some DCBS questions. So I'm just trying to make sure that there's a time when I should be bringing those up, if it's now or if I should be waiting on that.
I think it's fine to bring them up. We're just a little bit short on time if it's just
Yeah.
brief. And I do want to make sure we put this on the agenda for February 4th to get to the straw proposal. The timing is such that we'll have almost 2 weeks before the board meeting. So I think that we can submit this straw proposal to the staff for the board to deliberate on at the next board meeting. So I do want to make sure we get to that on February 3rd.
Yeah, so I think the questions are fairly quick. So one of them is related to the hospital revenue question. And so this is a OHA question. They account the net patient revenue as coming from either Medicare, Medicaid, private insurance or commercial, self-pay or out of pocket. And I'm wondering if for each of those, well, let's suppose I go to Medicare. The Medicare portion, is that the allowed charge or the amount that is allowed to be charged that comes in as net patient revenue? And if it's for a Medicare patient, do they break out the portion that comes from Medigap into commercial, or do they leave it in Medicare? And do they break out the portion that's out of pocket and put that in self-pay, or do they leave that in Medicare? A similar sort of question for commercial. Is commercial really all coming from commercial, and then the portion of a commercial claim that comes from out of pocket, is that put into self-pay, or is that all considered part of commercial? And so it's kind of like this breaking out it's not clear how it's accounted for in the financial statements that hospitals provide to OHA. So that's one question, or I guess a number of related questions there. And I can make it clearer what those are in more detail. DCBS provides health enrollment quarterly reports, and I have those reports from 2019 through 2023, and I would like to get that for 2018 as well. So that'd be one particular question. Another is that the Oregon Division of Financial Regulation provides a market share and loss ratio for line of business, accident, and health. And I have a 2023 PDF that Morgan was able to get into a Excel spreadsheet. And it'd be nice to have that as an Excel spreadsheet for 2018 through 2022 as well. It probably already exists. Somebody probably just has it hanging around as a spreadsheet, but if they have it as a PDF, that can be put into a spreadsheet, so it'd be good. But that 2018 to 2022 data would be good to have as a backdrop to check against some other data for those years. Anyway, that's my general requests for more data. Regarding the straw proposal, I can provide a slight update to, well, I guess the straw proposal in general would be similar to what I did early on, which is the general overall estimates of what's in what category, which is kind of the first page of my document. And that is, I can refine it slightly by, soon, by the next meeting, by the February 4th meeting. But it won't have everything well refined. I think I can get through a few more, well, I could probably get through Medicare a bit, so that might be a bit more refined, but I don't think I can get to the commercial part by then. So
I think for a straw proposal, that's okay. So just share the update that you have with the committee in advance of the February 4th committee meeting, and then we discuss, and we can add caveats, or we're still in process on X, Y, Z, but this is where we're at, or something like that. Morgan, do you have any thoughts about that?
Well, just to clarify, for the February 4th meeting, we would need materials so that the committee would have enough time to review in advance of the meeting on the 28th. So that's just a week from today. So I think whatever you can get into the straw proposal form earlier, so that the committee has enough and the public have enough time to review and then allow for public comment, since that would be something like a recommendation to the board. We just need to make sure that there's enough time in there.
And so could you maybe give me an idea of like what you want in the format of the straw proposal? Is it pretty much what's on that first page of the summary page of the spreadsheet, or is it something else? I mean, you don't have to do it this meeting, but if you could get that sort of a format to me, that'd be wonderful.
Yes, the board reviewed like official straw proposal categories. So there's a whole bunch of meeting materials that have been requested and follow up. And when we send out those materials and post them on the website, I'll also send that to you, Charlie, so you have it.
Thanks.
Thanks, Morgan. And Richard.
Yeah, as Charlie said, my concept of the straw proposal that goes to the board will be in the form of a spreadsheet that follows the NHEA accounting. And that we've started with numbers derived from imputing from national numbers, but Charlie's done a huge amount of work to refine it more specifically for Oregon, and we'll show those numbers. And we'll also list those things that might be in or might be out of the universal health plan. To wit, we'll put all the medical numbers, again, as a beginning place for the straw proposal, all the medical numbers for long-term services and support in the number that adds up to the plan, and then we'll exempt those that are for custodial care. And the same thing might be for Indian Health Service, or might be for the VA or the DoD or the TRICARE. We'll put them in either the in the plan column or in the out of plan column. It doesn't mean that we're making a decision. It's up to the board to make a decision. But the idea is that on one spreadsheet, the board can see what's in and what's out of of the straw proposal, and then
Right. Well, we can get to recommendations as a committee to propose to the board on any of those components, like long-term services and supports, for example. But also be really clear on our assumptions that we're proposing to them, so they understand what we're doing. Jeff?
This is a little different topic on the reflection for next step. Since we last met, the number of 17 to 20 billion net new additional revenue has been rattling around in my head. And so with Megan's assistance, pointing me in the right direction, I was asking the question of, what percentage of Oregonians have some kind of medical coverage, whether it's good, bad, or somewhere in the middle. And it turns out to be about 97%, according to the OHA information. And it caused me to reflect and think about, we're using as a standard right now OPEB benefit across the board for every Oregonian, and which is an admirable goal. But if we could get every Oregonian covered, which is the remaining 3%, for a substantially lower number, that is not a bad outcome, because we're covering those who do not have it. And I would be interested in my colleagues on the task force here, what their thoughts on that. Am I barking up the wrong tree, or is that something that we should explore? Thank you.
Thanks, Jeff. Does anyone have quick thoughts on that? I know we need to move to our agenda planning, and a couple of things I wanted to tell you from the board too, before we then go to our public comments. So just a couple more comments, and then we need to move on. Charlie?
So to me, that's a project for a different group. So the and the reason I say that is because my expectation is that if we propose a reasonable universal health plan, it'll actually cost less than more. Rather than costing more, it's going to cost less. And people will have better coverage, and there will not be underinsurance. So the fact that 3%, I think uninsured is not, some predictions or some estimates in Oregon are that, but most estimates are a little bit higher than that. And the underinsured group is pretty large. And so what we're proposing is not having anybody underinsured either. And it's going to cost less because, and so to insure the last bit of people who are uninsured in Oregon is going to definitely cost more. Now, Jeff's point about, how is this being paid for? Taxes would be much greater under a universal plan than they would be for just covering a few more people, but overall costs would probably be higher rather than lower. So to me, it's a different kind of a proposal than what I'm hoping the governance board is trying to do. So thanks.
Thanks, Charlie. John?
Yeah, my recollection from the task force is that covering the uninsured was about another $1 billion. Now, realizing there was the task force was talking about residents, not citizens, but residents. And again, sometimes the uninsured numbers are citizens, sometimes it's residents. Since the task force, to its credit, the state of Oregon has launched Healthier Oregon, which focuses on residents. And has, there's hundreds of millions of dollars there. And to their credit, they've done the bridge plan, which I think gets another 100,000 folks who are uninsured. So on the revenue side from the state, there's more. So those wheels are turning. The other issue I would just mention, Cheryl, in terms of long-term care, is the board needs to, there's really three issues. I don't think there's any controversy about the plan should cover the Medicaid and Medicare post-acute care costs that are related to, the sickest folks. It's to what degree should the plan administer the, if you will, a nursing home and benefit, which is currently administered by DHS. That gets back to the administrative services issue. And then the third issue is, and it's the big one, and I think it's a $2 to $4 billion issue, is does the plan cover long-term care for all the residents in Oregon that it covers for everything else? That's the big one. But the administrative issue is also so tricky. There's a reason why Oregon kind of divides that money up and sends part to OHA and another part to DHS, and DHS does really the nursing home portion, I believe. So.
Thank you, John. That's certainly another very complicated issue for sure. Charlie, do you have a very quick comment? Because I need to get to.
I do. I mean, actually, most of what DHS does is not nursing home, but home and community-based care. But yes, they do the nursing home portion as well. Just quick comment. Thanks.
Yeah, good. Thanks, Charlie. So for the fourth, the agenda on the fourth, of course, remember this is a 2-hour meeting. I think we should focus on, obviously, the health expenditure straw proposal for a big chunk of that. And then the other thing that's come up, this was a request by the board at the last meeting, was to look at the 2025-27 biennial budget for the Universal Healthcare Governing Board, review the review the budget request that's been made already, look at the contractor budgets, and look at the existing budget to compare, and just see if we can recommend any input on the budget process and to add to the budget if needed for finance and revenue. I think every committee is looking at it and seeing if they have recommendations for increases, because now's the time. We're here in legislative session, so we would need to submit those requests to the board and then going to the staff. So I think we should spend some time on that. I don't know if we have any extra time to talk about anything, but some of the topics are, we didn't go into ERISA very deeply. We didn't go into administrative costs very deeply. So we'll see what we get to, but those two things probably should be the highest priorities. Any thoughts about that? Or yeah, okay. I'll talk with probably Jenny a little bit more about the schedule, and of course that will come out on the 28th with whatever Charlie has to share on that straw proposal and the budgets that we were just talking about. I wanted to let you know that I did talk to the operations committee chair. He feels it is too soon for us to meet jointly on federal revenue and waivers, but if we have any questions for their committee, he's happy to discuss. So if you have questions on waivers, they are going to just start talking about them in February. So we've got time for that. We can ask some questions. The second request was from a different committee, the Communications and Community Engagement Committee. They'd like to share information with the public on health expenditures and the revenue plan. And they're wondering when we might have something for the committee to start collecting feedback from stakeholder groups, or if there's a particular piece of information we'd like to share, or maybe even ask the community, the various community groups, or like focus groups. I think there are 5 or something. We could ask them, that committee, to ask them certain questions that would help us help inform the revenue plan. So think about that. We don't have time to talk about it. Perhaps we can discuss this at the February 4th meeting. Those are the two pieces of the two communications that I wanted to share with you. I don't know if we have time to talk about this. I'll leave this up to Morgan, but with Morgan's departure, we wanted to mention what the support for the committee might look like. I don't know if Morgan or other staff know this yet, but Morgan, do you want to say anything about that before we shift to public comment?
Sure. So the board action at the meeting last week on Thursday was to appoint Jenny Donovan as the interim executive director. Jenny is currently the operations and policy analyst for the board. And she's the primary point person for the communications and community engagement and operations committees. So she will move into the interim role and support the board and those two committees. And then while she's in that role, she's going out for a job rotation to fill the operations and the policy analyst, and that policy analyst on job rotation will step in and continue and start to support the finance and revenue and plan design committees. So what I've told the board and Jenny is that I am working very hard on this side in the next couple of days to do whatever I can to help draft agendas, work with Cheryl on the meeting PowerPoint presentations and just some of those things, so that there's kind of like a pick up the agenda and get going and continue to work with Cheryl and the committee for the February 4th meeting. So we're hoping that it will be seamless for you all, and I've told the board that I will do everything I can to help ensure a smooth transition and get as much work done prior to my departure to support the committees, so that policy analyst on job rotation will be able to hit the ground running when they come on.
Thanks so much, Morgan, and thanks, Jenny, for agreeing to be interim director. Appreciate you. So we're going to slide into the public comment. Again, we received one written public comment providing several recommendations on taxing certain healthcare workers differently, other sources of tax revenue, and a question on the use of HSAs and a universal health plan. And I understand there's one public comment today, so I'm gonna move to that person. I don't remember the name of the person.
Yes, it is Richard Walsh. And Richard, you can go ahead and take it away. And please just remember that you have 2 minutes. I'm not going to put a timer up, so I'll just trust you to do your best. And we can't hear you yet, Richard, if you are talking.
I still can't hear him, so I don't know if his sound isn't working.
Darn it. Well, Richard, you are definitely welcome to write up those comments, and we can absolutely get them to the Finance and Revenue Committee. Otherwise, you can join us on February 4th, and I'm sure they look forward to your comments then as well.
Yeah, I'm sorry we couldn't hear you, Richard.
Sorry about that. Yeah.
So with that, I'm going to adjourn. We all have our tasks to do in between meetings, and thank you for all of your work and investment in finance and revenue. Have a good day. Bye, everybody.
Be well.
Bye-bye.
You too.